Today we'll start our IC on eyelid malpositions. I am Dr.Manju Meena. Okay. Shall we start or wait? Okay. Do we have a timer here? Timer. It's 9. Shall we start? Okay, good morning everyone. Myself, Dr. Manju Meena. I'm an oculoplastic surgeon from Jaipur. We will be talking about various eyelid malpositions. And it's a basic instruction course regarding the various eyelid malpositions. First of all, we'll have Dr. Peter Macintosh. He'll be talking about palpebral spring in the management of Lagophthalmos. So we'll keep his talk as the first talk in this session. So I'll welcome him to the dais. He's a professor in the University of Illinois, Chicago.
Good morning. Thank you for the introduction, and thank you for inviting me to speak. I apologize, I have to leave right away to catch a flight, so thank you for allowing me to speak first. Before we talk about eyelid reanimation, I thought we should just talk a little bit about some anatomy and how all of this relates to facial reanimation. So the facial nerve nucleus, as we all know, is located in the lateral midpons. It then travels around the nucleus of the sixth nerve and then exits the brainstem. Importantly, after it exits the brainstem, it travels through the facial canal in the temporal bone. And this makes the facial nerve special related to other cranial nerves because it's the only one that travels through this armor of bone. And we think that this is one of the reasons that the facial nerve is more susceptible to inflammation because there's not a lot of room in here for swelling if there's an inflammation or infection. So the facial nerve is particularly susceptible to this because of this particular anatomy. It then travels through the stylomastoid foramen and then exits and branches through the parotid gland, making a number of branches that have different branching patterns, but ultimately these all innervate the muscles of facial expression. An important note here is that a supranuclear lesion causes a slightly different pattern from a peripheral nerve lesion, and that helps us understand the difference between a peripheral nerve and a stroke. A patient with a stroke will present with just lower facial paralysis because there's bilateral innervation to the upper part of the face. A peripheral nerve lesion will affect both the upper and lower. So that's a quick way to determine acutely, do you think this is a stroke or not? This series by Homan and Hadlock looked at the different causes of facial paralysis, and this is consistent with a number of other series, and by far and away the most common cause is idiopathic Bell's palsy. Followed by that are tumors and then various other infectious etiologies. Peterson then evaluated the prognosis after idiopathic Bell palsy and showed that the vast majority of patients will end up doing very well. On this score, a score of 0 is normal facial function, and a score of 4 is considered flaccid paralysis. And the vast majority, 71%, had a score of 0. 1 and 2 are considered acceptable. And so really only 4% of patients ultimately will go on to need some kind of chronic intervention for paralysis in the face. So how do we evaluate facial paralysis? We look at this man and we can easily pick out some of the problems here. He has brow ptosis, he has lower eyelid retraction. You might not be able to see it, but there's probably some upper eyelid retraction because of the levator that is no longer countered by the orbicularis, flattening of the nasolabial fold, and the lateral oral commissure as well. There are a number of grading systems that have been created to evaluate and also monitor the progression of facial paralysis. This is called the House-Brackman score. There's another one called Sunnybrook and an electronic one called the eFace. But all of them tend to evaluate the face in zones. So House-Brackman evaluates the brow, the eye, the nasolabial fold, and then the oral area. But I think we as ophthalmologists recognize that this probably doesn't capture eye function as well as we normally do just on a regular clinic visit. Here they're looking at weakness of the orbicularis, and they assign a percentage to that. Is there asymmetry? Is there movement? But we probably think of the eye a little bit more sophisticated than that. We measure brow position, upper eyelid position, we assess the health of the cornea, we assess the lower eye position. And so I think that when we're looking at this, especially as ophthalmologists, there's not a very good established grading score the way they have for facial paralysis that we do for the eye itself. So here is a little girl, and we can see some of the issues in this video. She doesn't have a lot of brow ptosis, but she can't elevate her brow. Here you can appreciate the upper eyelid retraction compared to the other side, the lower eyelid paralytic retraction. She does have some lagophthalmos, even with full forceful closure, and then she has lower facial issues here as well. Oh, sorry. One other thing that I wanted to mention was her blink. So if you look carefully when she blinks, the normal right side compared to this side, soon you'll see it. And I think what I'm going to argue is that although she can forcefully close maybe 50 to 75%, if you watch the blink on this side and compare to the other side, like there, she really doesn't blink at all. And so I want to talk a little bit about blinking. Blinking is a temporary closure of the eyelids that doesn't interfere with vision, but is very important for maintaining the tear film and protecting the eye from foreign objects. At rest, we blink about 16 times per minute. When we're a little more socially engaged, we tend to blink a little bit more. And as we all know, when we're reading, working at a computer, patients complain of dry eye. That's because we actually blink a whole lot less. The blink happens literally in the fraction of an eye, in 0.3 seconds, closure to open. And the closing velocity is about twice as fast as the opening velocity. Another important point is that the eyelid during blink has an anterior-posterior movement as well to provide kind of a squeegee action against the eye, to distribute the tears and also brush away any foreign debris. So there's a number of techniques to manage paralytic lagophthalmos, and we're going to start with some static techniques. And these are the things that we use acutely because if we're not sure what or how much recovery we're going to get, we don't want to proceed to very invasive procedures yet. So things like aggressive lubrication, taping the eyelid at night, moisture chamber glasses, cumbersome but work well, temporary tarsorrhaphies. Again, these are very effective, but they don't look good. But this may be very effective in someone who has an acute Bell's and you're just waiting for it to resolve. The permanent tarsorrhaphy, again, is very effective at closing and protecting the eye, but it's not very pretty. And finally, lower eyelid suspension for paralytic lower eyelid retraction. Now, there's two dynamic techniques that I want to talk about, and there's many others that we could, but these are the two, and probably the most common one is the upper eyelid weight load. Typically, this is a gold weight, although platinum is also commonly used. The advantage of platinum is that it's 10% denser than gold, and so gives a lower profile when it's implanted. Also, there's some thought that it's more hypoallergenic. And a pocket is dissected through the orbicularis and the skin, and the gold weight is typically sutured to the tarsus. There are other techniques to place it in other places, but this is probably the most common location. And so here's a man standing up. He has paralysis of the left side of his face. And here you can see the weight. You can see it poking through the skin a little bit. He still has a little bit of lagophthalmos nasally, covers most of his cornea. But the thing I want to bring to your attention is look what happens when he lies down. He has supine Lagophthalmos. So here, standing up, when he lies down, because the vector changes, when the patient is standing upright, the eyelid weight is being pulled down by the force of gravity. As he lies down, the vector changes, and in fact, it's counteractive, and it pulls the eyelid open. So this is an important thing to consider in patients when placing a weight. What happens at night when they're sleeping and they're at their most vulnerable? So here is our patient again. She's now had a weight placed in the left eye. And the first thing I want to point out is that it completely corrected the upper eyelid retraction that she had. And watch now with forceful closure. She has much better closure than she did before, but look at the speed at which it happened. I showed you earlier some data that demonstrated a blink happens in 0.3 seconds. This closure, forceful closure, if you wait long enough, sure, it goes down, but it takes 1.5 to maybe 2 seconds. Sure, that sounds fast, but that's still 5, 6, 7 times slower than a normal blink. So what can we do that's even better than a weight? And so next I want to talk about the palpebral spring. And I like to compare this to a safety pin. It has an upper and a lower arm and a fulcrum, and this is where the power comes from and means it does not rely on gravity. Importantly, these candidates have to be properly selected. Patients who are expected to have long-term paralysis and have maybe had a poor response to medical or conservative therapies. The Bell's phenomenon doesn't matter, but most importantly, we need them to be cooperative. This surgery takes a lot longer than a gold weight and requires a lot of intra- and post-operative cooperation from the patient. It's made from stainless steel or nickel cobalt alloy and is very, very thin. We then bend it into this shape with the fulcrum laterally and place it through a standard upper eyelid crease incision that's converted into a lazy S over the lateral orbital rim. And here you can see the lower arm is then sutured to the tarsus. The fulcrum is sutured to the lateral orbital rim, and the upper arm is sutured to the superior orbital rim. One of the complications historically had been migration and exposure of the implant, but that has been ameliorated by placing the lower arm into a Dacron envelope and suturing that envelope to the tarsus, and that prevents the extrusion of the device. One of the issues is that the more the eyelid opens against the spring, the greater is the spring tension forcing the lid closed. And because of that, many of these patients develop pseudotosis postoperatively, and one of the ways to manage that is then to add a levator advancement to provide a little bit more lifting action of the levator muscle. So here's a patient who had a spring placed, and you can see the device in the lid and also that pseudotosis that I talked about, but look at the speed of the blink and how complete the eyelid closure is with the spring. So even as she blinks, there's a blink, there's better closure of the eyelid, and also if she were lying supine, because we're not relying on gravity, she still has complete and full closure. This study compared the outcomes of the weight versus the spring, and we can see in both the categories of the gain in blink and the gain in closure that the spring is better. And the one thing I do want to point out is that although the spring is very effective, the main complications has to do with postoperative adjustments, a whole lot more than if you place a weight. So in summary, remember the eye zones, not just the face zones when managing facial paralysis. Remember to think about supine Lagophthalmos. What is happening to your patient when he or she is lying down? The blink is important for tearworm preservation, and therefore we want to really try to reanimate the blink and not just closure itself. And finally, consider static versus dynamic eyelid closure techniques. Thank you.
Thank you, Dr. Peter. Any questions for Dr. Peter?
Yes, sir.
Tension in the spring itself, so that the tension becomes less, and then you don't have to advance the.
Right. So
is there any other material? what I mean to say basically is that is there any other more malleable material which you tried using apart from stainless steel, because that can be quite rigid?
Yeah, that's a really good question, and I think it's an internal limitation of the design of this device. Because the more it opens, the more tension is put in the spring. I agree with you, maybe we could consider a different device, but then maybe it wouldn't have enough tension to close the lid as the alternative to that. So that is one inherent limitation that I think is difficult to overcome. And so that's why some people are talking about different types of devices, like a device that closes based on innervation from the contralateral eye. That's probably the holy grail of how to manage this, where if we provided a cross-face innervation to a device that then closed based on innervation from blink from the contralateral side, that's probably the best way to address this. We don't have that technology yet, but that is an internal limitation of this particular device, and I think it's difficult to correct it with this technology.
And how much has been your exposure rate?
Corneal exposure?
No, the exposure of the device.
In my experience, it's been zero. Again, the main reason for that is that we're suturing the palpebral arm to the tarsus. Many of them historically in the 60s and 70s when this device was developed were extruding because they were simply placed in a preorbicularis plane, and therefore they constantly were putting tension on the orbicularis in the skin and they would erode through it. But now that it's being sutured to the tarsus, that erosion exposure rate is very, very low. And in my experience, it's been zero.
What's the thickness of the wire that you use here?
It's 0.01 inches, and I apologize, I don't have the conversion to metric.
And the material you said is either stainless steel or?
It's a nickel cobalt alloy, so it's safe for MRI and airport scanners.
Thank you.
Thank you. Thank you.
Okay, we'll begin the session now. So I'll give an overview of various eyelid malpositions. How to change the slide. Okay. So first of all, I would like to introduce the team here. We have Dr. Vikas Menon, who is the head of Department of Oculoplastics, Center for Sight Hospital, New Delhi. Then we have Dr. Sima Das. She is the head of the Department of Oculoplasty at Shroff Charity Eye Hospital, New Delhi. And unfortunately, we don't have Dr. Santosh Unava. He doesn't need any introduction anyway. And we have Dr.Surbhi D Joshi. She is a renowned oculoplastic surgeon from Vadodara. So I'll be talking about the basic eyelid malpositions. So basically, the eyelid malposition, it is a condition where the eyelid position is not in normal position. That could be due to various forces which acts upon the eyelid margin. It is a relatively common disorder and can, if not treated properly, it can lead to various visual and functional problems. So first of all, we should be aware of the anatomy of the eyelid. So what we have in the anatomy, there are three layers: the anterior, middle, and posterior layer in both upper and lower eyelid. In the upper eyelid, the anterior lamella is formed by the skin and orbicularis. The middle lamella is formed by the septum and the retractors, which is a levator in the upper eyelid and inferior retractors in the lower eyelid. The posterior lamella is formed by the conjunctiva and tarsus. So there are various structures which are responsible for maintaining the normal positioning of the eyelid, which are tarsal plates, the orbicularis oculi muscle, the retractors of the lids, and the medial and lateral Tenthon tendons. So if they work in a balance, then only the eyelid will stay in normal position. So any change in these structures can lead to distortion or malposition of the eyelids. The common malpositions which we see in our routine clinical practice are blepharotosis, eyelid retraction, Entropion, Ectropion, and Lagophthalmos. So there are various anatomical factors which are responsible for the malposition of the eyelid, like horizontal laxity, deficiency of anterior posterior lamella of the eyelid, prominence of globe, any globe and eyelid disparity, abnormality in the tone of the orbicularis oculi muscle, or any abnormality in the retractors. Entropion is a common condition which is characterized by interning of the eyelid margin. It is produced by disparity in the length and tone between the orbicularis oculi muscle and the posterior lamella of the eyelid. It is classified based on the etiology into 4 categories: involutional entropion, cicatricial entropion, acute spastic entropion, and congenital entropion. The treatment, there are various treatment options available, but that will be decided based on the etiology and type of entropion as well as the severity of entropion. Ectropion, as we know, it's an outward turning of the eyelid, which is caused by various conditions. If there's any problem with the horizontal eyelid laxity or vertical eyelid laxity, or if there's a disparity between the globe, then patient can have outward turning of the eyelids. It is also divided into 2 categories, congenital and acquired. The acquired is further subclassified into involutional, mechanical, cicatricial, and paralytic ectropion. There are various treatment options, but that also would be decided by the surgeon based on the type and grade of the entropion. All these will be discussed by my colleagues in subsequent presentations. And blepharotosis, which is also known as drooping of the eyelid. It is classified into 4 categories based on the etiology, like myogenic ptosis, aponeurotic ptosis, neurogenic ptosis, and mechanical ptosis. There are different surgical options available based on the severity of the ptosis as well as the levator function. And the non-surgical options in these cases are crutch classes, which is reserved for those cases who are not fit for surgery, where the LPS is poor and the BELS is also poor, where we cannot operate. Then we have eyelid retraction. It is considered to be present if the patient, looking in primary position, if the superior limbus is visible. It may be, generally it is acquired, but can present at birth also. It is divided into 3 types: neurogenic, myogenic, and mechanistic, based on the etiology. The treatment is generally levator recession, spacer graft, or gold weight. And as Dr. Peter explained about the sling, that spring, that can also be used. Then Lagophthalmos, it is an inability to close the eyelid completely. And if the patient is unable to close the eye properly, the patient can have corneal exposure and keratitis, which can be very dangerous to the vision of the patient. So the causes are generally facial nerve lesion, weakness of the orbicularis muscle, and sometimes can be mechanical displacement of the eyelid can also lead to Lagophthalmos. The treatment is depending on the condition of the patient. If the patient has exposure, we can give them lubricating drop or some soft contact lenses. The patient can be advised some temporary measures like taping of the eyelid at night. A temporary tarsorrhaphy can also be done. The other options would be tarsorrhaphy and gold weight implants. And this is another condition which is known as nocturnal Lagophthalmos, which is generally present in normal population also. Here the patient has partial opening of the eyelid at night, and generally the patients are normal. There is no symptom as such, but you can find, on slit lamp examination, you can see some punctate epithelial erosions on staining. The treatment is generally lubricating eye drops or taping of the eyelid at night. Floppy eyelid syndrome is an underdiagnosed entity, generally seen in middle-aged male, and the patients are generally, if you look at the profile of the patient, they are generally obese, overweight. So we need to ask about the history of any sleep apnea or any other sleep disorder. So these patients generally we need to treat them with a sleep medicine therapist. Along with them, we can treat these patients, and they have a history of chronic papillary conjunctivitis, which is resistant to the conservative treatment. And generally what happened in them is they have this horizontal laxity of the eyelid, and they have spontaneous eversion of the excessive laxity of eyelid at night, and because of the mechanical rubbing of the eyelid, the tarsal conjunctiva with the pillows, it can cause
chronic papillary conjunctivitis, chronic discharge to the patient, and that's why they are not responsive to the treatment, to the conservative treatment. So the option in these cases is shortening of the horizontal shortening of the eyelid, and it is quite effective in these cases. And we also have to monitor this patient with a sleep medicine therapist. So all these conditions, before planning any treatment, we have to have a proper examination. We have to see the condition of the eyelid margin and the position of the punctum. We also have to look for the, what is the extent of the eyelid laxity, what is the tone of the muscle, orbicularis oculi muscle. There are various tests which are available, which we can do to judge the orbicularis oculi muscle tone and the strength. And then we also have to look for the tear meniscus height, if there is any associated eyelid problem like distichiasis or trichiasis. We also have to look for the corneal involvement like exposure keratoconjunctivitis, and then we can plan the treatment for these cases. So this is the overview, and my colleague Dr.Surbhi Joshi will cover Entropion now. I call Dr.Surbhi Joshi to the dais. Thank you.
Good morning, friends. Thank you for having me over, Manju. Entropion, as we all know, probably it is one of the most common eyelid malpositions that a general ophthalmologist would probably encounter in his day-to-day OPD. The main reason for entropion is the disparity in the functioning and attachment of the lower eyelid retractors, along with the laxity of the lower eyelid that is mainly seen in patients with increased aging. Grossly, you can classify them into these broad groups. Coming to the history and examination, once we go ahead with the symptomatology, on examination you should proactively look for the lower eyelid tone. We have 3 tests that have been described: the distraction test, the pinch test, and the laxity test. And these, they generally give you an idea about how much lower eyelid laxity is associated with either the disinsertion or loosening of the lower eyelid retractors. One should also look for associated corneal pathologies if they are coexisting due to the long-standing entropion. And obvious scarring or keratin deposition on the tarsal plate should be looked for. Usually it progresses as these 3 grades. Once it goes into the grade 1, that is when the patient starts having symptoms, and usually they present at the grade 3, where the complete eyelid is turning inside. Involutional of these is the most common variant, and initially when they present in the early stages, you would like to offer medical treatment to these patients. Supportive treatment of lubricants, taping, and BCLs. They can be used in patients where they want to buy time for surgery. Temporary taping can be advised. You have a small piece of Meditape which can be applied against, in the reverse pull. You pull the lid down and apply the Meditape on the cheek, but this is very short-lived and patient might not want to use this for longer time. Again, moribund patients where they are taking time, where they cannot be taken for surgery immediately, transverse everting sutures. You use suture materials which will induce fibrosis and hence lead to some amount of eversion of the eyelid. Though when you're looking for long-term results, you would go for definitive surgical management. Weiss had described a procedure where you transversely completely divide the eyelid just below the tarsus, and you kind of resuture it in a form where a fibrotic band is formed, due to which the eversion is possible. The horizontal eyelid laxity can also be addressed with this procedure. Jones procedure being the gold standard in management of senile entropion. You begin with I will go through the steps. You begin with a subciliary incision. Skin orbicularis is open. You would then expose the orbital septum. Once you open the septum, you would see the fat prolapsing, and just beneath the fat, once you retract it, you would identify the lower eyelid retractors as a white glistening band of muscles. Gently pull them and suture them to the lower border of the tarsus, judging adequately what amount of correction is needed. You might not want to overcorrect, because in these cases, if you tend to overcorrect, the patient would end up with lower eyelid and punctal eversion. That would eventually make him more symptomatic. Addressing the horizontal lid laxity along with Jones is very important, hence a pre-op assessment helps there. You would want to combine Jones with a lateral tarsal strip in cases where you have associated horizontal eyelid laxity. The tarsal strip is created in the lower eyelid laterally, and that is attached to the lateral orbital rim. This would in turn lead to tightening of the lower eyelid. Here are some of the pre and the post photographs, and this wound heals really well. The scar would not be visible beyond 6 months. But this is adequate correction. If you tighten more than what is needed, then you might end up with eversion. Cicatricial entropion, most commonly seen in the upper eyelid, is because of scarring of the posterior eyelid lamella. Most of the times it is associated with secondary disorders, as we all know, and they need to be treated primarily. When this stage sets in, you would want to address the upper eyelid. So the principles of repair are these three. You might want to lengthen the posterior lamella or shortening of the anterior lamella. Based on these principles, we have various procedures which are described. The wedge resection of tarsus is very helpful. You go from the skin approach and you would want to remove a strip of the tarsus once you expose the skin orbicularis, and beyond that the suturing is done, which would in turn lead to eversion of the eyelid. The results are pretty good, just that you might have to go through a skin approach. The alternative that is available is the terminal tarsal fracture, where you actually evert the eyelid and go and divide through the scar line and take everting sutures with the material that would lead to good amount of fibrosis and leave the lid in that position. The results of this procedure are pretty good and satisfying. Patients where you have severe scarring and a lot of keratin deposition on the posterior eyelid, these patients do very well with a oral mucosal graft, where you might even address the trichiasis in the same setting, and they take up really well. Other grafts that can be taken, the principle of taking a graft is you might want to have mucosal lining on one of the parts so that eventually you are giving a smooth surface on the palpebral side. So these are the other alternatives that can be taken. Spastic entropion happens mainly in patients which have ocular surface disorders, and because of the excessive blinking, the pre-septal part of the orbicular is overriding on the pre-tarsal part, and it is more or less hypertrophied in those patients. That is where you see the spastic entropion. These are the causes, and medical management definitely helps. Botox has a role to play in cases of spastic entropion, where there is overriding. Botox to the preseptal part of the orbicularis, the patients do really well. So they can be managed non-surgically. There's one entity which is congenital entropion, though not very common. It is associated with developmental anomalies, and it's mainly in the lower eyelid which is commonly seen. The insertion is affected. In the upper eyelid, there is abnormality of tarsus which would lead to congenital entropion. One interesting fact, you need to differentiate between entropion and epiblepharon in children. Epiblepharon is more common, and you need to understand that once the child grows, epiblepharon is self-correcting. So you might want to offer a transient treatment in these kids, probably something like a filler injection in that excessive fold which is there, which would transiently correct rubbing of the eyelashes on the cornea. Whereas if it is entropion, you might want to treat them right away because they are not going to be corrected by non-surgical method. A close differential to congenital is entropion is the horizontal tarsal kink, and you need to differentiate between the two. So, like any surgery, entropion correction also has complications. You need to, though they are not very common, you need to be watchful. Thank you.
Thank you, Dr. Surbhi. Now we have Dr. Vikas Menon. He'll be talking about tackling entropion. Sorry, ectropion.
Good morning, everyone. Thank you, Dr. Manju, for having me here. So I'll be talking about ectropion. So basic anatomy and this evaluation part has already been covered by Dr. Manju. Just to reiterate that ectropion is a state where the lid margin tends to move away from the globe. And this is how we assess the horizontal lid laxity, which is important part to be addressed when you're tackling ectropion. And then you move the lid medially and laterally to assess the medial and horizontal and lateral canthal laxity. To understand ectropion, we can classify it as congenital or acquired, and the acquired may be involutional, mechanical, cicatricial, or paralytic varieties. Congenital ectropion can happen either because of an intense conjunctival inflammation in a newborn, or a newborn having floppy eyelids, or a rare entity called ichthyosis, where the skin is scaly, and that leads to cicatricial form of ectropion even in newborns, and sometimes it has been seen in Down syndrome children as well. However, in adults, usually the most common variety of ectropion that we see is involutional ectropion that happens as a result of laxity of the lids caused by aging. Then we have paralytic ectropion, which was also discussed in the first lecture also. That happens because of paralysis of the facial nerve. Floppy eyelids is a separate entity whereby the lids become very loose and lax, and it's very easy to evert the lids. These patients also need to be screened for obstructive sleep apnea. The standard workhorse treatment modality for treating ectropion of the eyelid, lower eyelid particularly, is the lateral tarsal strip procedure. What we do here is basically we separate the tarsal plate, we do a lateral canthus incision, do a lateral canthotomy, inferior cantholysis, and then we remove this skin and the conjunctiva from the lateralmost part of the tarsal strip. So we make it, that's why it's called a lateral tarsal strip. Now once that de-epithelialized strip is formed and you have it here, then you pass two Prolene sutures and anchor this strip to the periosteum of the lateral orbital rim after removing a part of the tarsus which is redundant. So when you pull it out, you will know that how much of the tarsus is redundant. You just excise that bit and then you anchor and fix the lateral edge of this tarsal plate to the periosteum. That gives a very good kind of a tightness to the lid, and it corrects the ectropion, even more severe ones, with almost an invisible kind of a scar. The other way to deal with horizontal lid laxity is pentagon excision, and you just go, you mark a pentagon on the eyelids, and usually it is made at the junction of the lateral 1/3 and medial 2/3 of the eyelid, and you excise full thickness pentagon of the eyelid, and then you close it by direct suturing in 3 layers. The disadvantage of this procedure is that sometimes in a cosmetically conscious patient, you may end up with a linear or vertical scar, and that may be annoying to the patient. Medial canthal laxity is a little more challenging to address because of the vital structures present there. You have to take care of the canaliculus whenever you are tightening the medial canthal tendon, because you don't want a kinking of the canaliculus, which would itself become a cause of epiphora. And so what we do most of the time is, although there are techniques to stabilize the medial end of the tarsal plate to the periosteum here, but there's only so much you can do here, because if you try to tighten it too much, then obviously there are chances of the canalicular kink. So what we resort to most often in practical situations is that we excise a diamond of conjunctiva from just below the punctum, about let's say about 3 millimeters or 4 millimeters below the punctum, excise a diamond, and then we close it in a vertical direction, this incision, so that it's causing an inturning of the punctum. Now this corrects the punctal ectropion. At the same time, you do some other procedure as well to correct the horizontal lid laxity. Either it can be a lateral tarsal strip or a pentagon excision of the lid if you feel comfortable with that. This is an example of a patient who presented with a punctal ectropion, which was managed with a medial conjunctivoplasty, as we call it, and a lateral tarsal strip. Now, another entity is tarsal ectropion, whereby the tarsus is completely everted. This happens because sometimes the lower lid retractors give way, and because of the detachment of the lower lid retractors, and if the lid is not so lax, the tarsus just everts outside completely. Over a period of time, the conjunctiva becomes thick, the mucocutaneous margin shifts posteriorly, and so it's cause of a significant distress to the patient in terms of watering and discharge that accompanies this entity. So a simple lateral tarsal strip doesn't work here. There are various options. One is that you reattach the detached retractors, but what I've seen is in long-standing cases where things have become a little old and chronic, even that doesn't work very well. So what I prefer to do is to do a lateral tarsal strip, and I pass inverting sutures. And inverting sutures are nothing but simple silk sutures or catgut sutures that we pass from just beneath the tarsal plate and exit them on the skin and tie them on the skin side close to the orbital rim. So this tends to make the lid straight, and when coupled with the lateral tarsal strip, this tends to treat tarsal ectropion effectively. This is a patient who had kind of a tarsal ectropion, and he was treated in the same way. You can still see the catgut sutures here. So lateral tarsal strip with inverting sutures is a good idea to treat such patients. Mechanical ectropion is caused by a lesion which is kind of heavy and is pulling the lid away from the globe. Only thing is, obviously you need to remove that lesion, but the point here which I would like to emphasize is that when you take out these lesions, try to make your incision as vertical as possible, because if you excise these lesions with a horizontal cut, then the resulting cicatrization may cause more ectropion. Then coming to the last part, that's the cicatricial ectropion. Cicatricial ectropion can be a result of trauma, burns, various cicatrizing skin conditions, skin tumors, some medications or allergies, and it can be very severe, particularly in chemical injury cases, and this can lead to the severe exposure and corneal decomposition. So one option for treating milder cases of cicatricial ectropion is to do Z-plasty. What we do in Z-plasty is we make two almost equally sided triangles, and then we rotate the flaps here with each other to change the direction of the scar. Basically, if we have these two triangles, consider these two triangles, you will move this triangle upwards and move this triangle downwards. So this will change the direction of the scar and lead to an effect of elongation of the anterior lamella. In more severe cases, however, you need to resort to skin graft. This was a patient who had cicatrization of the upper eyelid as well as the lower eyelid, and this patient required skin grafting on both the upper and the lower lids. And another patient who had a cicatricial ectropion of the lower eyelid, she required skin grafting on the lower eyelid. And the important thing here is whenever you're doing a skin graft, you need to put a traction suture or sort of a frost suture, so that the graft has a tendency to contract after some time, and in that phase of healing, when the graft can still contract, it's important to maintain that stretch on the eyelid so that whatever you have done, your efforts don't go waste. Another young patient who had a post-traumatic the cicatrization of the lower eyelid causing ectropion of the lid margin, and again a skin graft was done which was taken up well, and the ectropion part was corrected to a reasonable extent, I would say. I'll conclude here. Thank you very much.
Thank you, Dr. Vikas. We can take questions for the speakers if you want. We have mics here, so anyone has a question for Dr. Vikas? Okay, now I invite Dr. Sima Das to the dais. She'll be talking about eyelid retractions and the causes and management.
Thank you, Manju, for letting me to be part of this IC. So I will be talking about the eyelid retraction, which is a pretty common condition which we see in our clinics. So if you have to classify the retraction, it can be like based on the etiology, whether it's a neurogenic cause, whether it's a myogenic or a mechanistic cause, or we can divide it into an acquired or a congenital category, whether it's involving the upper eyelid, both eyelids, or just the lower eyelid. and whether it's unilateral or bilateral. So before you go into the management part, it is important to differentiate it from a pseudo-retraction. So like, for example, this patient came with the complaint that his left eye looks a little more prominent. What he actually had is a ptosis in the other eye. If you see the MRD in the other eye, it seems to be pretty low, and there is a compensatory overaction of the levator of the other eye, which causes this appearance of a retracted globe. So this needs to be ruled out, and this needs to be pointed out to the patient, and many times the review of the old photographs actually tends to convince the patient, look, this is the eye which is like what the patient feels sometimes is kind of is having the problem, is actually not the problematic eye, it's the other eye. So going on to the myogenic causes, thyroid we know is the most common cause of upper eyelid retraction. It can be unilateral, it can be bilateral, it can present in various stages, but most of the time what we see are the retraction comes in the burnt out stage of the disease when the acute inflammation has gone, when the active stage of the disease is already over. Now this lady has this asymmetrical bilateral kind of retraction, more in the right eye, much more, but if you see the left eye, that also has a little lateral flare. Characteristically in thyroid, the lateral part of the eyelid seems to be much more retracted than the medial part. Probably something to do with the lateral part of the levator, which is much more stronger, and this, since the cause remains an increased innervation because of the circulating catecholum, means probably the levator tends to get kind of a little more retracted on the lateral side. Also, in the chronic stage, what we see are the inflammation and the scarring which follows the active phase of the disease. So important here is, before you jumping on to manage this patient, is to control the thyroid dysfunction. Now if you see this lady, she has this upper eyelid retraction, she seems to have a little bit of congestion, used to get this on and off mild activity sort of picture, some redness, congestion, which used to go off just with topical lubricants and steroids. Her thyroid was still uncontrolled. Now once we control the thyroid status, this was what the picture was. It actually sometimes tend to kind of improve the retraction if you control the thyroid status. So doing a surgery at this stage will not be an appropriate idea. Let the thyroid come under control, and then whatever residual retraction is there, we can always take care of it at a later sitting by surgical or non-surgical means. For a temporary correction of the retraction, Botox injection to the levator muscle is a good idea. If the patient does not want surgery, or if suppose the thyroid is not under control, you cannot take up the patient for surgery straight away, we can inject a little bit of Botox into the levator muscle via a transcutaneous or a transconjunctival route. I prefer a transconjunctival route because the chances of getting a ptosis is little less by this route, and the dose can be about 2.5 to 5 unit, and you usually tend to inject it just at the upper border of the tarsus, at the lateral and the medial side, and can avoid the central part so that you don't get an unexpected overcorrection. So it gives a decent amount of correction. Like this gentleman had a active disease, we can see a little bit of congestion and chemosis here, but he had to attend a marriage. So he wanted to do some correction for this kind of retraction so that the pictures doesn't look that obvious. So we gave a little bit of injection to the levator, and it was not fully corrected, but yeah, decent enough to kind of make the pictures little more probably better. This kind of conditions, we don't have any other option but to go ahead with a tarsorrhaphy. Tarsorrhaphy is usually not done for cosmetic purpose in thyroid eye disease, but essentially for functional reasons like severe corneal exposure, severe disease causing exposure, keratopathy and all. So, and it can be temporary or permanent depending on what is the status of the cornea and depending on what is the indication you are doing it for. But the definitive surgery for recession, for retraction usually remains an levator resection. A recession procedure which is done via a transconjunctival or a transcutaneous route. So this is a small clip about the levator recession procedure which has been done by the transconjunctival route. So what you do, you incise the conjunctiva at the upper border of the tarsus after everting the eyelid, separate the conjunctiva from the underlying molars and the levator muscle, levator aponeurosis, and undermine the conjunctiva a little bit so that all these adhesions are kind of free. Otherwise, whatever recession of the levator you do, that is not going to go back and give you the desired amount of correction. So once that is done, you identify the levator aponeurosis, levator molars complex, incise that all throughout, specifically on the lateral part to take care of the lateral flare, which is quite prominent in the thyroid patients, and again undermine it on the anterior surface of the levator. Again, make it free. Basically, the aponeurosis become free anteriorly and posteriorly, so that it can now easily recess. How much amount to kind of undermine and recess I prefer to go by the intraoperative correction. You do the surgery under minimal amount of anesthesia so that the patient just have analgesia but no akinesia, so that you can assess the correction with the contralateral eyelid on table. So leave it just corrected or maybe slightly over-corrected on table. And usually, as a rule, we tend to see that the eyelid tends to move up a little bit in the post-operative period. So if your first post-op day, the patient seems to be fully corrected, then probably it's not a very nice scenario. You should not be very happy, but a little bit of overcorrection on first post-op day is what you desire, 1 or 2 millimeter overcorrection. Then over the period of next 1 or 2 weeks, you expect it to come to the position where you want it to be. So this is the pre and the post-operative picture of one of the patients who undergone this procedure. Coming to the mechanistic causes, trauma and post-surgery remains the most common ones. These kind of pictures are pretty common. I'm sure all of us must have seen this. A badly repaired eyelid laceration, which the primary sitting would have been the best scenario to handle the, to avoid this kind of picture. But doing like if it's a localized sort of retraction, very kind of localized to one particular part of the eyelid, you can just manage it with just doing a pentagon excision, depending on the laxity of the eyelid. If not, a diffuse sort of retraction obviously needs a skin graft, which Vikas has already shown the photographs. I'm not going to the details of it. And like this gentleman was managed with a pentagon excision with a little bit of 5-FU injection to take care of the residual scar, whereas this lady had to undergo a skin graft because the scarring was more diffuse here, not a localized one. In the mild cases, intralesional 5-FU is a good option where you want to avoid the surgery or maybe as a pre-operative or a post-operative adjunct measure. And it usually is effective in the initial stages of the scarring, where the scar is still red. It's not a white scar. It's not a mature scar. So you can inject it into the scar, and you can give multiple sittings, which can be spaced over a couple of weeks. And it basically loosens up the scar and can correct a mild amount of retraction, like what happened in this patient. One more thing we have to be careful is to find out what exactly is causing the retraction. Sometimes in thyroid, it's not the eyelid only which is at fault. It's the globe, the prominence of the globe, which actually tends to push the eyelid upwards or downwards. So if you don't take care of it, or if you don't identify that cause and do an eyelid surgery before taking care of the prominence of the globe, then you will not get a desirable result. Like in this lady, because of the prominence of the globe, the eyelid, since the globe prominence usually happens in the slightly lateral direction, you tend to see the lateral flare much more common. So the lateral part, the highest point of the eyelid actually shifts a little bit more laterally. Now, just by doing a decompression, you are actually bringing the highest point of the eyelid more towards the center, back again. These are the pre-decompression and the post-decompression photographs where you see that the prominent part of the eyelid is actually shifted lateral, more medially, once the globe goes back. So this patient doesn't even need any surgery for the eyelid retraction. So this is important to identify it. Post-surgery, again quite common, post-osis surgery, aponeurotic repair. The results are quite unpredictable. They quite commonly land up with overcorrection and retraction, and all you have to do is to kind of adjust it once again. Post-Entropion, tarsal fracture, the upper lid procedure that we do very frequently. If you do not recess the levator, the upper fragment of the tarsus, what you recess while doing the kind of tarsal fracture procedure, if that is not recessed nicely, post-operatively you might land up with an eyelid retraction because you are essentially shortening the posterior lamina of the eyelid. So it's important to recess that to avoid that post-op retraction, which can be very severe at times, causing exposure keratopathy. So this patient, you have to lengthen the lamina once again by putting a spacer in the eyelid. So this was one of those patients who had undergone a Cutler-Bayard procedure, and we all know after Cutler-Bayard, if you don't give any support for the posterior lamina, patients can land up with an Entropion along with a retraction of the eyelid. So this lady also had to be, a cartilage graft has to be done to support the posterior lamina and to lengthen the eyelid to take care of that upper eyelid retraction because her cornea was getting bad. Another patient where, again, this was a post-traumatic, post-chemical injury, in fact, patient where the tarsus has undergone necrosis in the acute phase of the injury, and he landed up with this Entropion and a shortening of the upper eyelid, essentially shortening of both the posterior and the anterior lamina, more of the posterior lamina. So even after an evisceration procedure, doing a mucous membrane graft, he still had this retraction of the upper eyelid for which a prosthesis fitting was not possible. So we again lengthened the upper eyelid by using a cartilage graft for the posterior lamina. So lower lid retraction, there can be various causes again, and how you manage it, it depends on the etiology. If there is horizontal laxity, you do eyelid shortening. If there is no laxity, essentially you recess the retractors or you put a spacer. So these are the photographs which I have taken from Dr. Vikas. These are the pre and the post-operative photograph for one of the patient who has undergone a recession of the lower lid retractors. And if for patients where the lower lid retraction is associated with a prominent globe, it's a good idea to lengthen the eyelid by using a spacer rather than only doing a recession of the lower lid retractors. If suppose there is an associated hollowing of the lower lid also along with the retraction, then you can give some volume by use a dermis fat graft, not just the dermis, but some fat also. This study was published from LBPI. This is one of the reports from the LBPI, in fact, where a temporary correction can be obtained by injecting fillers into the lower eyelid retractors, lower eyelid to kind of stand the eyelid little up and take care of the retraction. Neurogenic, again, various causes, aberrant third nerve degeneration, myasthenia, facial palsy remains the most common cause, which Vikas is going to talk probably, and we had it in the first lecture also, so I'm not going to the detail. So to conclude, eyelid retraction actually causes a lot of functional and cosmetic implication, and we need to assess the patients properly and formulate an appropriate treatment guideline to give the satisfactory outcome. Thank you.
Thank you, Dr. Sima. Is there any question for Dr. Sima? Okay, now I invite Dr. Vikas Menon for, he'll be talking about the evaluation and management of Lagophthalmos.
A part of this lecture was covered in the morning earlier, so it may seem a little bit repetitive, but then there are certain differences also in the way in which how we approach, given the limitations and of our settings here. So I don't have any financial disclosures. So Lagophthalmos, as we know, is an inability to completely close the eyelids, which leads to a gap when the patient tries to sleep or blink, and which may lead to certain ocular sequelae which may be unpleasant, as this or even this. So none of us want this to happen in our patients, and if it is there, then we would like to give maximum comfort to these patients. The etiology of Lagophthalmos can be varied. Most common is facial nerve palsy, which may be because of Bell's palsy, as was described in the morning. Surgery, trauma, or CVA. Then it can be because of cicatrization of the eyelids, which leads to incomplete closure. Maybe a prior eyelid surgery. Sometimes it's not because of any problem with the eyelids, but proptosis, which is not allowing the lids to close properly. And even floppy eyelid syndrome patients have Ectropion, as well as when they sleep, their eyes tend to open up and they may have a little bit of Lagophthalmos. And the lady on top has all the features of the facial nerve palsy, as was described by Dr. Peter, I guess, in the morning. And this patient has suffered chemical injury to his left eye and is unable to close the eye. When we proceed for evaluation of Lagophthalmos patients, then basic things that we need to record and document in our files is palpebral fissure height, MRD1. We need to measure in millimeters how much is the amount of Lagophthalmos. Other thing that we need to assess is the lower lid laxity, and if there is any upper lid retraction, we need to measure that. You need to assess and record the blink rate, check the ocular motility, check Bell's phenomena, corneal sensitivity, look for the adequacy of tear film breakup, and look for any SPKs or other frank signs of exposure keratopathy. Conservative measures should not be underestimated. In fact, most of these patients can be managed with just conservative measures, and you don't really need surgery in majority of them. Intensive lubrication and just advising them to apply a small tape on their eyelids at night. Moisture chambers, if available, and punctal occlusion can help to minimize the effects of exposure, and these should be tried first. The surgical management basically will depend on two things. One is whether you want a temporary or a permanent kind of treatment to these lids. Suppose there is a situation like Bell's palsy, which is going to improve on its own, and after 6 months or 1 year it's going to become better. You don't want a permanent procedure on that patient. You would rather do something more temporary here. And the second thing that you would like to assess before you proceed with surgical management is that whether it's the lower eyelid or it's the upper eyelid which is contributing more to the Lagophthalmos. As we might think that the upper eyelid is only the culprit in causing Lagophthalmos, it's not always true. In many times, the upper lid may not be at fault, but the Lagophthalmos may be just because of the lower eyelid malposition. So Bell's palsy recovers good on its own in about 83% of cases. One thing which you can suggest to the patient and maybe you can add is steroids and oral acyclovir, especially if the patient reports to you in the first 3 days of presentation, and that can actually hasten the process of recovery. Then in cases of Bell's palsy, you may resort to temporary measures like tarsorrhaphy. It's ideal for cases with combined 5th and 7th nerve palsies. The only disadvantage is that it causes restriction of lateral field, and if you do it centrally, sometimes it may be difficult to assess the corneal status. Botulinum toxin comes in handy in such a situation. It will allow a better assessment of the cornea on subsequent visits. Dr. Sima talked about Botox. You just have to go in the midline posteriorly and inject into the levator muscle. That will induce ptosis, which will last for about 2 to 3 months on an average. The only drawback is when the patient is sleeping, it can lead to passive opening of the eyelid, and you still have to advise taping along with this. Now I'll just go over some cases, particularly give you some examples. Now this is a situation where the upper lid doesn't seem to be causing too much of a problem, but it's because of the lower lid which is contributing more to Lagophthalmos. So what you do here is, you know that it's mainly the lower lid problem. So what you do is just correct that. And you don't always have to deal with the upper lid in all cases. So lateral tarsal strip, as mentioned, is the workhorse procedure. You take out the tarsus and you, as I previously mentioned in my Ectropion talk, and you anchor it to periosteum, and this corrects the Ectropion as well as it improves the Lagophthalmos, because the lower lid is now resting at a higher level and it will improve Lagophthalmos. This is a patient who had bilateral Lagophthalmos, and only thing that was done for this patient was a lateral tarsal strip. The lower lids were loose, they were tightened, lifted up slightly. Upper lid was not touched, because many times if the upper lid is unaffected and you try to do something to that, you will cause more ptosis, and that is something which the patient may not want. But if there is a predominantly upper eyelid contribution, then there are options like levator recession, as Dr. Sima just showed you previously in her talk, and lid loading. That was talked about briefly in the first lecture. So these are some of the cases, some of the examples, and you may combine the lower eyelid and the upper eyelid procedures wherever you feel both the components are contributing to the Lagophthalmos. This patient had significant Lagophthalmos in right eye. In fact, it seems almost entirely open when the patient is trying to close the eyelid. In this patient, both LPS recession and lateral tarsal strip were performed, and you can very well see the improvement in Lagophthalmos. Another patient who had upper eyelid as well as lower eyelid problem. So both the procedures, levator recession and lateral tarsal strip, are performed. I tend to lean more on the levator recession part rather than lid loading part. I'll come to that why. So lid loading has been a standard procedure to manage Lagophthalmos for a long time. And what we do basically is we put implants made of gold or platinum in the upper eyelid, and we calibrate the weight as to how much we need to put in, and basically because of that weight the lid is passively pushed down when the patient tries to blink. The aim, what we target, is that we want a minimum 50% reduction in Lagophthalmos at the cost that we should not get more than 2 mm ptosis in the patient. So there are various sizes and thickness which are available, and we titrate that first. The surgery, however, is very, very simple. You just have to open the eyelid, go down deep to the septal level, and insert the gold plate, which has got 3 sutures here. And once you've placed it there, you just push it further inferiorly over the tarsal plate and anchor one part to the tarsal plate, and the other two, it has got 2 holes here, which are anchored to the septum. And then the skin orbicularis are closed over it. So it is a good technique, no doubt. It corrects Lagophthalmos, as in this particular patient who had Lagophthalmos because of a facial nerve palsy. And you can see here that Lagophthalmos is corrected significantly. Another patient, this was his Lagophthalmos post tarsorrhaphy. And so in this case, tarsorrhaphy was opened up, and this patient is now without tarsorrhaphy. There is still residual Lagophthalmos, but it's much better than before, and it can be, he was comfortable with just use of lubricant subsequently, so it didn't feel like doing more procedures for him. Another patient who had significant Lagophthalmos in the right eye for a long time, and this is how his Lagophthalmos improved with gold weight implant. And on straight gaze also there is a little bit of ptosis, but it's not significant. His pupillary axis is clear, he's comfortable. But it's associated with certain complications. That is, implant extrusion is the commonest complication because it's a foreign body, it induces a reaction, and sometimes it just migrates out of the skin. The other problem which I find is that, the gold weight implant is visible. It's visible as a thickening on the eyelid surface, which may not be desirable, particularly in young patients who want a better cosmesis. So that is the reason why I prefer to do a levator recession rather than a lid loading procedure in these patients. Moving on to patients with cicatricial kind of a Lagophthalmos, these cases have been discussed earlier, and again you need to assess how much is the cicatrizing effect, and then you plan either a Z-plasty or a skin graft to improve the Lagophthalmos. And thank you very much.
Thank you, Dr. Vikas. With this talk, we'll conclude this session. If there's any question for Dr. Vikas, we can discuss, or any of the speaker, if you have any question for them. Yeah. Use the mic.
My question is on ptosis. Patients of CPEO, chronic progressive external ophthalmoplegia. So what will be the best management for them?
It's a difficult thing to treat. You have to take into account the patient's motivation, from where the patient is coming, how much follow-up he can give. If the patient is very motivated and follow-up is not a problem, you can do a kind of a minimal elevation with a silicone sling. Silicone sling has an advantage that it's a little more elastic than any other rigid material or suture. So it will provide a little bit of control, a better control. You just have to elevate that much of lid which will just expose the pupils and not too much. There have been other cases, other procedures which have been reported in which you lift the lower eyelid higher by putting a spacer in the lower eyelid, and then you lift the upper eyelid by doing some sort of ptosis surgery. So that will actually shift the palpebral aperture a little upwards. It will maintain the size, but the problem that happens with that procedure again is that earlier the exposure was happening inferiorly, and now the exposure, if it happens, will happen centrally. So what I find best is to do a kind of a conservative sling surgery. Yes, I don't like them much. I don't prefer them much. They're very uncomfortable.
I have experience in crutch classes. Nowadays, earlier they used to make those metallic prongs which goes inside and they insert it. They were quite heavy and the patient were not very comfortable wearing them. But nowadays they are coming up with those acrylic prongs. It just goes inside in the sulcus and the patient is very comfortable as they are lightweight, and they have slight flexibility, so they can use it. They can even blink the eyes also sometimes. So they are very comfortable using. Nowadays I am using them in those glasses only. But yes, CPEO, if the Bell's is very poor, then it's always better not to do any surgery in those cases because of the risk of exposure keratopathy. So always advise them crutch glasses. The ocularist or these people who make spectacles, they are well aware of these crutch glasses, so they can advise them. Okay, thank you. Avoid surgery whenever possible in such cases. Question? Facial letter for what, sir? Okay. As a spacer graft. Graft in that. Okay. Yeah. I don't have any experience in that. We'll conclude the session then. Thank you. Thank you everyone for attending.